Are we live now?
Yes, sir. We are live now. We can go ahead.
Okay, Hitesh,
Yeah,
just share your screen and get started. I think
yeah,
today we have Dr. Hitesh Shah from Manipal talking to us about approach to a child with cerebral palsy, and that should be extremely valuable for everybody. So Hitesh, please go ahead.
yeah. Thank you. Good evening, friends. I'm going to talk on the topic which is very common for the throughout the India, the approach to a child with cerebral palsy. I'm going to talk the few points which is very basic and relevant for the postgraduate and the junior consultant, pathogenesis of the locomotion disability, points on the clinical examination, what are our goal of managing a child with cerebral palsy, and basic principle of management of cerebral palsy. Though it was a topic of the approach to a child with cerebral palsy, it is mandatory to mention what is cerebral palsy. It's a non-progressive neurological disorder due to the damage to the immature brain. It is very relevant to mention it's a problem in the brain is non-progressive, and that may be due to the perinatal problem at the brain injury. Always mention that brain injury is non-progressive, but the effect would be progressive. So this is the very basic understanding of the cerebral palsy. What the orthopedic surgeon and other people, physiotherapists, occupational therapists, do see the effect of the cerebral palsy on all four limbs, both upper limb and both lower limb. Due to the growth, the effect, the spasticity, contraction, everything would be a progressive, but the brain damage is non-progressive. I'll come to that point by the history and examination. Due to the involvement of the brain, there is a primary impairment like the spasticity, balance issues, strength, selectivity, and sensation. And because of the primary problem, that will affect the joint and bone, lead to the contracture and deformity. And if it is not corrected, it can lead to the tertiary problem by like hyperextension knee or complication of the hip joint like hip dysplasia in hip dislocation. I'm not going in detail, but it is very basic to understand why the function of the limb would be compromised, the why child will become disabled throughout the life because of the spasticity. Basically, that is of biarticular muscle, muscle imbalance, coordination, involuntary movements, and paresis. There is a problem in brain, and what we are dealing with the limb problem. And we need to make it very clear what any intervention, orthopedic intervention would be operative or non-operative intervention. It can only address the spasticity and few extent the muscle imbalance. We don't have at this time good treatment for the involuntary or incoordination or paresis. These are very, very relevant for managing a cerebral palsy. The most of the patient of cerebral palsy would be spastic. Very few will have the involuntary or dystonic CP, but the major issue of the cerebral palsy will be having spasticity. So few points why they need to have a spasticity. And because of the brain involvement, there would be loss of the inhibitory control, and the reflex, which is a stretch reflex, would be hyperactive, and that is a velocity dependent. This is also very relevant for the understanding a child with cerebral palsy, because if you see the child in calm and good position with good environment, the spasticity would be less. And if child is not familiar, then the spasticity would be more. And that is from subjective, from one person to other person, it varies. And that is the reason it is very, very relevant to understand the spasticity. And if the spasticity is not getting controlled by the physiotherapy or medicine, it can lead to the deformity and it can lead to the impair the function. The spastic muscle fails to elongate during a growing year. These are the another very important concept, because the fourth dimension in pediatric orthopedic is growth. as the child grow, the bone will grow, but muscle fail to grow. And this, I will give you the good example. Like this is the figure of the leg with tendo Achilles or the gastrosoleus with tibia. And it's normal child, as the bone and tibia and fibula grow, along with that, that's muscle also elongate. But in case of the cerebral palsy, if there is a spastic gastrocnemius, they fail to elongate, it can lead to the permanent contracture and deformity. These are the very relevant point for the spasticity. So the function would be also compromised because of the deformity, and that can develop during a period of time, that is on growth. The spasticity, muscle imbalance, and deformity can be addressed by the orthopedic intervention. Second issue, why the muscle imbalance. The group of muscle acting on joint would be stronger than the antagonist. Like one group of muscle would be powerful, while opposite muscle would not be powerful. The simplest example is muscle across the knee joint. If the hamstring would be powerful and quadricep would be weak, that can pull the patient into the crouch gait. Similarly, at ankle joint, if the gastrosoleus is powerful and tibialis anterior is weak, that can lead to the permanent equinus deformity. So we need to detect the underlying muscle imbalance in case of the cerebral palsy. These are the very basic fundamental of the cerebral palsy, why the function of the limb would be compromised. Coming to topic, that's the approach to the child with cerebral palsy. Whenever we'll see the child with cerebral palsy, it is very important to ask very quick the history. Why did it happen? What are the positive points on the history? Because in many of the DNB and postgraduate examination, they'll ask, why do you think so? The diagnosis of cerebral palsy. If there is a history of birth asphyxia, patient is low birth weight or admitted under an ICU, you can think about the cerebral palsy, one of the risk factors for developing cerebral palsy. The most important history would be developmental milestone would be delayed. The developmental milestone would be also delayed with some of the congenital anomalies of lower limb, but it's not only the walking is delayed, all the gross motor and fine motor developmental milestone would be delayed. And the most important are the no sign of regression of milestone. What is it? If the child has achieved the sitting control, and if sitting control gets lost, that means that is a progressive lesion of the brain. That is not a case of cerebral palsy. Again, I will repeat, if there is a contracture, it's getting it worsened, that is not the progressive of the brain. We are talking about the non-progressive lesion of the brain. What is non-progressive? Should have the developmental milestone would be delayed, but not been compromised. Same with the effectiveness in the limb function. Limb function may be progressive, affected. Second, it's important point, any child with the cerebral palsy, we need to assess the child at several times, because as I said, the spasticity varies from day to day, time to time, person to person, place to place. So the spasticity will not remain the same. So the message for the most of the postgraduate, whenever they do a single time examination, they can easily answer very quick and smart answer. I will like to reassess the child, and he would be absolutely right. And that would be also practice for the most of the consultant of the pediatric orthopedic surgeon. We need to do a systemic examination from the gross motor function classification system, look, feel, and move. I will go with one by one. An internationally well accepted classification is the gross motor function classification system. It is from the descending order. 1 is the best function and 5 is the poorest function. Why need to do about the classify this child into the whether it is type 1, 2, 3, or 5? Because the management depends on what GMFCS function classification would be there for the child. So that is very relevant for the management point of view. What is GMFCS 1? When the child can work or walk almost like normal. They don't need any support. That is GMFCS1, like community walker, as like any other child. GMFCS2, the child would be also independent ambulator, but that require occasional support by climbing the staircase or that. GMFCS3 always need supported device for that. GMFCS4, while walking, the child will require supportive device as well as the support of one of the guardian or parents. And GMFCS5, they cannot walk. They have the total body involvement with the poor head control also. As this is very important, we need to discuss it. So level 1 and level 2 are the independent ambulator. What is the difference between level 1 and level 2? Level 1 child can perform each and every activity unlimitedly, while level 2 child cannot run and jump and hop and may require support in uneven surface, crowded place or staircase. So when you see the level 1 child would be very active, level 2 child will require support on the climbing the stairs. This is very simple. Level 3 will require the support while walking aid, maybe the single walking aid or double stick or the double walking aid, or maybe the crutch, elbow crutches or the stick, and that is a GMFCS3. For the longer distance, they would not be independent ambulator, and that is the difference between GMFCS2 and GMFCS3. What is GMFCS4? Along with the supported device, they will require the assistance of the one of the parents, and that is GMFCS4. And for the long distance, they cannot walk also. And GMFCS5 patients are always the wheelchair bound, and that is specific wheelchair would be customized for the GMFCS5 because they don't have the poor trunk control as well as the head control. Why GMFCS would be important? Because if you manage the child as a whole, the deformity or the limb dysfunction, growth spurt or increase in BMI as well as the uncontrolled seizure, the GMFCS may lower down. So sometimes the patient would have not taken any treatment and GMFCS would be lower down, and after intervention GMFCS may be come down to its normal level. So but it would not jump after intervention from 4 to 1. So we need to be realistic for the managing this child. So that is the first step for finding out what is the gross motor function of the child, to find out the gross motor function classification system. Physical examination, I would like to divide the physical examination in several headings, like assessment of the spasticity, assessment of the muscle function, assessment of the selective control of the individual muscle, degree of the muscle imbalance across the joint, whether the bony or the joint contracture is present, the alignment of the limb in a liver arm dysfunction in a static, and the most important aspect of the examination, if the child is GMFCS 1 and 2 or 3, we need to always mandatory examine the gait analysis. So let us start with the spasticity. Again, I will say examination, repeat examination, repeat examination. This is not my sentence. This is sentence of the Eugene Black, and they said about the spasticity. The spasticity is a velocity dependent. So you need to stretch the muscle gently and very slowly. There are the various grading are there as Ashwath, modified Ashwath, and Tardiscroll. We can grade from 0, 1, 2, 3, 4. Modified Ashwath 4 has put into the +1. But there would not be increase in tone, would be 0, and the maximum tone would be there. The slight function throughout the joint motion, that would be a rigidity, will be a type 4 spasticity. Or we can say about the slow and fast stretch. That is, when you do about the slow stretch, it is called as R2, and the fast stretch, that is called as R1. And we need to do about the value of the difference between R2 and R1, that is called as the spasticity angle. If the spasticity angle is large, that means it is a large dynamic component. That means it is only a spasticity, and that would not be any contracture. If there is a small spasticity angle, that means R2 and R1 value would be similar. Difference is very, very less. That indicate there would be a muscle contracture. What I mean, we need to stretch the muscle. Suppose we are talking about the equinus of the ankle, we need to do about the first slowly do that. That is the R2, and do the about fast, that is R1. Slowly stretch means we can forcefully dorsiflex, that is R1. Slowly dorsiflex, that is R2. If there is no difference between R2 and R1, that is mostly contraction. I will talk on the how to examine about the gastrocnemius and soleus later. Second, assess the muscle power. That is, assessing the muscle power is not very easy in case of the cerebral palsy because of the spasticity, but it is vital and important to know about why the muscle power would be very relevant in case of the cerebral palsy examination. The length and strength of the muscles are always inversely proportional. If the length of the muscle is longer, it will be also always weak. And what are the muscle tends to go become longer? These are the very important anti-gravity muscle like hip abductor, knee extension, ankle dorsiflexion, and hip extension. This will keep the human erect. Upright position would be maintained by these are the muscles, and they may go for the elongation because of the spasticity of the biarticular muscle. Like the hamstring becomes tight, the knee extension become longer. Like flexion contraction, the iliopsoas become the short, the hip extension become longer. Gastrosoleus become gastrocnemius become the short, tibialis anterior become the weak. And as I said, the length and strengths are inversely proportional. These are the important muscle has to be checked. This is an example to check about the quadricep leg. And if the quadricep leg is there, the person will be walking with the crouch gait, like knee flexion. And that is a very important concept, is knee crouch gait would not be only related because of the hamstring contraction. It is maybe related to the quadricep weakness. Selective control muscle, this is also very important. It can be divided, like this child was asked to do dorsiflexion, was unable to do dorsiflexion. When child was asked to flex the hip, you can able to see there is a dorsiflexion of the ankle. That means it was not, it was considered as a tibialis anterior weakness, but the child doesn't have selective motor control of the tibialis anterior. It can be divided into 0, 1, and 2. 0 is no control, 1 is partial control, and 2 is completely able to control selectively motor control. Degree of imbalance, as I said, we need to know about the degree of imbalance across the hip joint, knee joint, and ankle joint to find out what is the imbalance. Whether the most important aspect of the cerebral palsy examination is the biarticular muscle contraction at the present. What are the muscle affected? In hip is adductor, rectus, and iliopsoas. At the knee joint, there are the hamstring, and ankle joint is the gastrocnemius. These are the common muscles as a biarticular. Biarticular means they cross two joints that gets contracted, and these are the spastic muscle. It has not been stretched, it can lead to the contraction. The hip adductor, these are the muscle for the upper limb pronator, wrist flexor, finger flexor, thumb adductors, that can lead to the upper limb problem. Hip adductors, flexors, the knee flexors, and ankle plantar flexion can contract. We can do the examination, the standard examination, by doing about the Thomas test to the iliopsoas contracture, do the prone rectus or the Duncan-Ely test. The basic of this test is that rectus femoris are hip flexor and knee extension. If we can able to flex the knee, the forcefully, we can see about the hip is getting flexed, and that is rectus femoris or the spastic or the tight. Another important muscle are the adductor contracture. Always check about the abduction of the hip in hip and knee in extension position to find out all the adductors. If you want to take out the the medial hamstring, you can check that in first hip and knee in extension and measure about the angle, and that would be the angle. And if the angle is getting it more by keeping the knee in flexion, that is Pleb's test. That means that there would be the abduction would be restricted due to the medial hamstring. If the angle is getting it more, that is not because of the hip adductor, because of the medial hamstring, and most commonly due to the gracilis. So you need to measure the angle between the midline and the thigh. At the knee joint, always examine the popliteal angle by doing about the straight leg raising test, or you can do from the vertical line to the angle of the tibia, and that is the popliteal angle. It is always necessary to mention what is the popliteal angle in a serial follow-up to know about the contracture is getting worsened or not. The most of the postgraduate face the cases like the equinus contracture, and equinus contracture may be due to the gastrocnemius or soleus contracture. So I will have some table how to check about the ankle dorsiflexion. Always check the knee extension, dorsiflexion of ankle in knee in extended position. If the knee is extended, if dorsiflexion is full, that means there would not be any shortening of the gastrocnemius or the soleus. If the dorsiflexion is not full in knee in extended position, that may be either the gastrocnemius or a soleus, or both would be contracted. So you need to do the flexion of the 30° of knee joint and check about dorsiflexion. If the dorsiflexion is full, that means only the gastrocnemius is affected, because the gastrocnemius crosses two joints, the flexion of the knee joint and the ankle joint. If the flexion of the knee joint keeps the fully stretched, that means only gastrocnemius is responsible for the poor dorsiflexion, passive dorsiflexion. If the dorsiflexion improve, but it will not be the complete, it will be the both the gastrocnemius and soleus. It doesn't improve in knee extension and flexion, that means it is only soleus is affected. Very unlikely to have the soleus is affected, but these are the very important test, and that is the test called as the silver scale test to find out whether it is a gastrocnemius or a soleus or a both would be contracted. You can see the example, when there is a knee is in extended, there would not be any 90° angle between tibia and leg. When you can flex, you can see the flex knee joint, the ankle can be perfectly dorsiflex, and that means there is a gastrocnemius contracture in this particular child. The last but not the least examination point is alignment of the static and dynamic examination. The static examination will require about rotational alignment of the both hip to know about the persistent anteversion or retroversion. If the internal rotation is more than the external rotation, the hip is in anteverted position. If external rotation is more than the internal rotation, that is hip is in retroversion. Second important point to find out the thigh foot angle, whether the thigh foot angle is the normal 20° in external. If it is foot is facing in inside, that means there is an internal tibial torsion. Another point, when there would be internal tibial torsion with midfoot break because of the tight tendo-Achilles, you can measure about the transmalleolar axis, dig about the longitudinal axis of the thigh and the perpendicular to the intermalleolar axis, and measure about the transmalleolar axis to find out whether it's external rotation or internal rotation. In the adolescent child, when the cerebral palsy with the crouch gait, the patella would not be in normal position. This is the normal position of the patella. At the lower part of the patella would be lined with the joint line of the femur and tibia. That would be a normal angle of the patella, level of that. It would be higher because of the elongation of the patellar tendon, and that would be lead to the poor cordyceps mechanism, and it will contribute to persistent crouch gait. That would be always necessary to get the X-ray in case of the crouch gait. So last but not least is whenever you will see the child with the walking, you can check about the Gait analysis in India, we need to follow about the observation gait analysis. Always check about in coronal plane, sagittal plane, and horizontal plane. You can see the limb is crossing each other, and this child is walking with the scissoring gait. Again, the heel is not touching, so it can be better detected in the side view. But in the front view, you can able to see that is a scissoring gait would be there. The most energy expenditure gait would be a crouch gait when there is a persistent knee flexion throughout the stance space. That was called as the crouch gait, and person cannot able to walk for a long distance. He has to sit after few walking distance, few steps of the walking. And the horizontal plane, if the person is walking, you can see the left side, the knee is crossing as well as it's going it inside. So that is the persistent the in toeing gait. So always check to spend some time and do analysis of gait in sagittal plane, coronal plane. Always check the hip, knee, ankle. These are the classical example, but you need to always spend some time. If you are new, always check about hip in coronal plane, sagittal plane, knee in coronal plane, sagittal plane, and in horizontal plane. In rare instances, we can have a dystonia. It's always need to differentiate dystonia and the spasticity. Spasticity we can feel, while dystonia we can see the tone would be varied from one person to other person. Generally, the child would be perfectly fine, and second time it would be distorted. The tendon reflexes would not be exaggerated in dystonia, and clonus would not be present in case of the dystonia. Pathological reflexes would be rare in case of this. Why need to know about the dystonia or spasticity, even though it is a rare? Because of we need to do about diagnosis, and the surgical intervention would be very limited in case of the dystonia, though the literature has changed it, but the traditional teaching is there. You need to be very, very careful in case with the dystonic CP before doing about the surgical incision. In the most of the cases, whether it is exam case or in a practice case, we need to find out what is the child, whether it is a spastic cerebral palsy or is a dystonic cerebral palsy, the type or geographic pattern, whether it's a one side upper limb and lower limb is involved, that is hemiplegic. If it is both lower limb are involved, that is a diplegic, or total body involvement, that is a quadriplegic. We need to find out what GMFCS score are there, whether the spasticity or contracture is there, the weakness of the muscle, very common in long muscle, liver arm dysfunction, version of hip, tibia, and foot, and the functional compromise of the patient, whether it is the hip is at risk or not, and expectation of parents are also very relevant. I will address few points on the orthopedic management of the cerebral palsy. The goal of management, as we are aware, there is a limb would be secondary involved, that is the involvement of the brain. The CP child will become the CP adult. What we are doing about the goal of management would be reasonable. We need to achieve the maximum function of independent living in GMFCS type 1 and 2 child, improve the function and minimize the dependence in GMFCS 3 child, and facilitate the care of the totally dependent child like GMFCS 5. So depends on the GMFCS, we can plan about the management. The surgery or any intervention would be required in one of the few categories. The sometimes intervention is required to improve the function. It's not always. Sometimes it will be required to improve the appearance. It's hygiene like thumb in palm or the perineal care, or to prevent the complication in GMFCS 4 and 5, the hip at high risk. We need to do about the intervention. Please understand the margin of error in disabled child is very, very little. It can make or break the child or a family. I'll discuss the management on following headings: spasticity management, muscle imbalance, deformity management, liver arm dysfunction, and function of the complication. The first and foremost option for the reducing the spasticity is the physiotherapy. And as I mentioned that in case of that, we need to do a slow and steadily stretch. We need to do a gentle stretch of the gastrocnemius. And that's why it is being evaluated again in R1 and R2. This is a correct way of doing about stretching. That is not in case of the pronated. We need to do about the inverted ankle, lock about the subtalar to avoid the midfoot break, and stretch about the tender Achilles. The first is the pronated foot and second is the inverted foot. That's invert and do about the stretching in a correct way of stretching. There is a role of orthosis. I'm not going in detail about articulated or non-articulated orthosis, but orthosis will have some role if the child has got the good selective control. It can be managed with the joint. The articulated or ankle foot orthosis don't have the control. It can be treated with the non-articulated AFO ankle foot orthosis. There would be some role on a binaural block. Whenever the spasticity is not getting controlled with the regular stretching physiotherapy, the basic function, the principle that it will block the binaural junction and it will affect, it can lead to the temporary paralysis of the spastic muscle. So it can be done with the Botox injection or the alcohol injection. In the developing country, we can treat with the alcohol injection. Intrathecal medication and selective dorsal rhizotomy, it's a neurosurgical intervention because that is very well used in a developed world. So we must be aware about this option, because if this facility will come in India, we can utilize it as and when it comes for the treatment of the spasticity. Surgery would not be any effective in case of the reducing spasticity. Always it is there for the correcting about the muscle contracture and bony deformity. Muscle imbalance, whenever the one is heavier and other side, we can make it the lighter side heavy or the heavier side the lighter. That's why we can do about that. The basic principle, the weakening of the strong muscle, either by the tendon lengthening. We can see the origin and insertion. We do about the lengthening, and that can be done by the surgical intervention on soft tissue, or the muscle slide. We can do about release from the origin of the muscle, like the pronator slide, that is useful for the in different conditions, but this is a basic principle of that. Or strengthening of the weak muscle, that are very important. Do either the physiotherapy or a tendon transfer. The weaker can be augmented or the stronger would be weakened. This is one of the options we can make it restore the muscle imbalance in case of the muscle imbalance. Treatment for the contracture, surgery by doing about the lengthening. Traditional Z lengthening would be utilized in most of the congenital disorder. It would not be a good option. Why? Because as I said, the length and strength would be inversely proportionate. The traditional lengthening can lead to the permanent lengthening of the tendon, and it would be irreversible. It would be associated with permanent weakness, like Z lengthening of tendon Achilles. It should not be encouraged in case of the cerebral palsy. So the option would be like a aponeurotic lengthening. So we can have the control length. It will not be exaggerated length in case of the cerebral palsy. Though the most of the lengthening would be done with the aponeurotic lengthening, maybe upper limb or anything on a lower limb. Surgery for the long muscle, it's required to do about the plication of the tendon. It depends on the age of the child, whether you do an proximal or distal. There are different techniques on that. I'm not going in detail of the technical, but we can do about the when you see in the left side, the patella alta is there, it's getting corrected with the all shots of the surgery. That is a patellar tendon shortening surgery. Deformity of the hip, whenever the hip has risk at dysplasia or the knee FFD or the plantar valgus, it can be corrected with the bony correction, either by the osteotomy of the hip, anteverted osteotomy, acetabulum osteotomy, or the femoral osteotomy, shortening and extension osteotomy of the femoral FFD or the plantar valgus by the calcaneum lengthening osteotomy. Liver arm dysfunction by the derotation, the femur anteversion or retroversion can be well corrected by derotation osteotomy, distal tibial derotation osteotomy, or the calcaneum lengthening osteotomies like Mosca. Hip dislocation should be treated very aggressively in ambulate and in non-ambulate also. We need to go about the good surveillance in the most of the cases to find out the hip surveillance, hip at risk, and it can be also having complication due to the iatrogenic over-lengthening of the tendon. Few points, few examples, the decision making, how the decision making, what are the variables we need to consider. The age, I said, it would not be very important to understand. It is very important to understand that these are the variables. We should not embark with any surgery less than 7 or 6, because the child would be growing, and as the child would be growing, the spastic muscle will follow the natural history, and we need to know about the non-operative intervention in a very small child. GMFCS, as I said, that the goal of surgery, goal of the intervention would be different in different GMFCS. Word of caution in whenever the child will have a dystonic movement, requirement of the patient, the soft tissue contracture, bony contracture, or the complication. GMFCS 1, 2, 3, improve the walking, prevent the deformity, or if it is deformity is there, correct the deformity. GMFCS 4 and my surgery for the hip and gait improvement surgery would not be indicated in a 4 and 5. Always do examination of hip, knee, ankle to do about the multi-level single stage surgery. Always plan the surgery at the same time to avoid the birthday surgery. It's a few cases. This is a child with the 5 years old, GMFCS 2, walking with the scissoring gait like that. In examination, there would be the adductor was spastic, hamstring was spastic, and gastrocnemius was spastic, but there would not be any fixed contracture. The child was treated with the initially physiotherapy. She did not improve, so it was treated with the myoneural block with the alcohol injection. The scissoring has been disappeared. The child is walking reasonably okay. The spasticity is there, but it would be less than the before. One child with the GMFCS2, because of the gastrosoleus, the spasticity, there would be secondary knee hyperextension, or the recurvatum was present because of the knee hyperextension due to the gastrosoleus, the spasticity. This child was treated with the myoneural block and the ankle foot orthosis in the 10-degree dorsiflexion. You can able to see the knee hyperextension has been disappeared because of the orthosis, 10-degree dorsiflexion orthosis. 17-year-old child previously having no treatment has walked like only the 10 or 12 steps with severe, the contracture is the elevation, having severe hip knee contracture along with the left side. The child has got severe contracture of the hamstring, patella alta, quadriceps weakness, muscle imbalance at the knee, and the equinovarus. The child was treated with the patella plication, femoral shortening, extension osteotomy, hip contracture release, transfer of the semitendinosus, and triple arthrodesis on feet. After 5 years, the child is walking reasonably well. It's an independent ambulator, but with crutches. His GMFCS has not changed, but function has changed a lot. So you can see the before and after is quite reasonably well on that. Last example, the 80-year-old child with the spastic diplegic, not able to walk, not able to sit without support, was able to sit comfortably, difficulty in sitting because of the hip pain, and we got the x-ray, the right hip was dislocated. So the child was treated. The parents' perspective, it was they wanted to have better sitting balance, perineal hygiene, and independent walking. They thought about we do intervention and the child will able to walk independently. But we need to explain that when we are dealing with the GMFCS, why the independent walking would be too much expectation. The child was treated with the open reduction, varus derotation osteotomy, and these are the follow-up x-ray. The hip is reasonably wide. The end result, child can able to sit comfortably. There would not be any pain. Perineal hygiene was better, but again, there would not be independent walking. I would conclude here my talk. Deformity and contracture would be due to the shortening of the biarticular muscle, has to be checked in every child with cerebral palsy. Muscle weakness would be due to the long muscle that is very common in hip extension, knee extension, and the ankle dorsiflexion. The liver arm dysfunction because of the short or improper liver arm would be there due to the anteversion. That may be the joint deformity in allulation, must be evaluated in every single child. Stretching of the biarticular muscle is the first line of treatment for the spastic and short muscle. Strengthening is the first option for the weak muscle. The child would be treated, the treatment would be tailored, depends on the requirement of the patient. The first option should be physiotherapy, then myoneural block, then orthosis. The surgery will have some role in a contracture release on that. And whenever surgery is required, you need to plan the single stage, multi-level surgery. That is a choice for the management. Thank you.
Okay, great. That was excellent. I'm sure there must be a lot of questions from people. So we should get started on that. Yeah. So I think we.
Good evening, sir.
Yeah.
Sir, I wanted to ask that considering the fact that sir told that one of the side of the muscles, considering like tibialis anterior is weak and the posterior compartment is strong, is there any role of serial castings for management of contractures like the equinus contracture at the ankle for a patient of cerebral palsy?
Yeah, actually, if the toxicity is not getting controlled by the physiotherapy, we can think about the casting, and that is also well described in literature. That is called as tone inhibition cast. So that is previously it was considered as the first step or before prescribing about the orthos. If we can prescribe the tone inhibition cast and the child is getting it better, we can prescribe about the orthosis. There is a role of the tone inhibition cast, but tone inhibition cast has not been popularized because there are literature on both sides. Poorly applied, the cast can lead to the pressure sore, and that can lead to the spasticity will get worsened. So that is the reason I have not mentioned about the non-inhibition cast here. But yes, it is a role of non-inhibition cast.
I think also if there's a contracture,
yeah, that is not.
It's unlikely to improve with casting.
Yes.
And if there is just spasticity, then usually you should be able to correct it to a reasonable position with under anesthesia. So it's not a serial casting that you would normally do. It would be a single cast for some time, or you would combine it with Botox or alcohol injection and then cast it in the corrected position. Is that correct, Hitesh?
Yes, correct. Single cast. That is tone inhibition cast.
Yeah.
So, sir, for DNB, it is open. The discussion is open. If you have any question, please ask.
So, Hitesh, there have been some reports of issues with Botox, and people, a lot of people, in fact, last time Abhay was here, they were talking about how they've reduced or almost stopped using Botox nowadays. What's the latest on that?
Yeah, that is a very important question because the Kerr-Graham group, actually Professor Kerr-Graham has having maximum number of publication for Botox. In year 2000, he used to promote the Botox or botulinum toxin regularly. What they have seen in the long-term follow-up and recent publication in August 2019, last year, they have evaluated in all long-term, that is called as sarcopenia. The repeated injection of the Botox can lead to the weakening of the muscle. Again, I said, what we see, the iatrogenic, the lengthening of the tendon Achilles, that can lead to the weakening of the gastrosoleus. Similar effect they have seen in case of the repeated injection. So they have one, and in fact, the Botox company, if you read the bottle in Botox, they have removed the indication in cerebral palsy. They don't want to disclaim that. They said we don't claim that it should be given. After that report, they don't. But basically, if you want to give, we can give for one, not in. So one single dose would be
not a problem. Okay, and in fact, I don't think FDA has actually approved it for its use in cerebral palsy.
Yes, because of that reason, they have not even disproved for the utility of the Botox in the cerebral palsy.
The counseling of parents is also important during the management. So what points you consider during counseling?
Yeah, the parents counseling is very important because these are the permanent damage in a brain. So the child would not be active like the clubfoot DDH. If we do intervention, clubfoot DDH or post-septic or a trauma, there would be perfect out. That is the possibility if they're present very early. In case of the cerebral palsy, whenever we do the parents' perspective, we need to know about what is their background, what is their expectation. If their expectation is really very high, we need to see what we are offering. If we see the child with GMFC 1 and 2, yes, we need to improve the function, we need to improve the walking, we need to improve the gait pattern. But if you see the GMFC 4 and 5, we cannot make into like GMFC 1 and 2. I can give my example. One of the parents here from Karnataka, the child was totally dependent, like a GMFC is fine, and he brought the child and say, make my child like us. He to say, no, it is not possible to get. Your aim is like that. He was extremely unhappy. But if you do any intervention, he's not going to change his GMFC. So we need to be very realistic in our approach with cerebral palsy. Otherwise, the parents and ultimately it will dissatisfy the entire family and
Yeah, I think a lot of parents come with the hope that the child will become normal. And I think that's something you really need to spend time explaining to them that this is, these children are never 100% normal. There will be some difference in the way they walk.
Yes.
They might be totally independent, but if someone is really looking carefully, there will be some difference in the gait from that of a normal child. So
that you are absolutely correct. In India, it depends on their socio-economical background. It would not be the same like if you practice for the city patient and the rural patient. You practice educated but our goal should be if you see GMFCS 4 and 5, I particularly take care more on hip, spine, and upper limb.
Yeah.
If I see about the GMFCs 1 and 2, I will take care about the lower limb and he can walk better without any complication. Like he should not develop the hip dysplasia or he should not have anything. And we need to do about long-term outcome would be good. So that should be our goal.
Okay, sir. And
other thing probably which I think has come again over a period of time is trying to delay surgery like TA lengthening or recession. Rather than do it early. Okay, so that's something again, Hitesh, I think maybe you should.
Yeah, that's the Reynold Brunner has discussed very nicely in his one of the webinar also. Like if we delay many times, the surgeon tends to do the surgery very early, but the problem is that as the growth, the muscle which we touch with the surgical intervention can lead to the fibrosis. And that is failed to elongate, and that can lead to the secondary problem, weakness and secondary problem. So it's better we can avoid the surgery. We can utilize the non-operative intervention, like we can do about take the child under anesthesia, see whether it is a spasticity or contracture. If it is a spasticity, do about binaural injection, give the cast, like the tone inhibition cast, then do about the orthosis and delay as much as possible.
Okay, sir, in books, they are written like dynamic spasticity and static type of spasticity. So for dynamic, it is Botox and all is working.
Yeah.
For static. So for dynamic, we can do tendon transfer also, sir, in that case? Or?
No, the dynamic is that when the child walks, when it is much more visible. So that is a dynamic. Static means in lying down position, in supine resting position, we can see what is the spasticity. The solution for the dynamic spasticity, how the child walks, whether it is a stance face muscle or the swing face muscle. If there is a stance face muscle, whether it is approachable with injection or not, then we can do about intervention. The common example when we see about the swing phase, that is tibialis anterior. So tibialis anterior would not be firing. Person would be walking like a foot drop. It will be the tibialis anterior would not be working, and it is the ideal treatment to do only orthosis, ankle foot orthosis, to prevent the foot drop in the swing phase. If the tibialis posterior or the medial hamstring would be the spastic, and as the child is straight during the physical examination, as soon as child walking, it's walking with in-toeing or the medial rotation or the mild flexion, we can block about the hamstring. So it depends on the what muscle it is working, we can do a intervention, whether it is considered in form of the manual block or whether it is alcohol or the Botox or by orthosis.
And sir, in your lecture, you mentioned about R1 and R2.
Yes.
So the difference between these two is dynamic spasticity, as I understood.
See, when you do about the slowly and fast, it doesn't make difference. Means if there is the joint doesn't come to neutral and both the difference is very little, that means it is a contracture. So number one, we need to find out whether it is a spasticity or a contracture. Whenever spasticity, surgery doesn't have any role. And when there is a contracture, the conservative treatment doesn't have any role. In very short, when there is a spasticity, no surgery. Whenever there is a contracture, almost surgery is necessary.
Okay, sir. And
In short.
regarding that spasticity, it's actually the pyramidal one and extra pyramidal like dystonia and all.
Yeah.
So in both cases, which one is better, sir? In prognosis wise?
Spastic is much
obviously.
Spastic is much better, and
And sir, both can means in one patient both can be there, sir. It's like that.
Yes,
like,
yes. It is mixed pattern. That is a spastic and dystonic. It's called as mixed pattern.
Okay,
So
sir.
these
So how
rheumatoid
does-
patients, etc., are much more difficult to manage.
Spastic is easy.
How will your treatment change when there is a dystonia actually? What, I know the prognosis won't be better, but what more care would you take in those patients?
At dystonia, we need to do about the repeated examination. Even in a spastic CP also, we need to do repeated examination. But in case of the dystonia, we need to be very careful before we do about any intervention. Yes, we do about even the hip is dysplastic in dystonia, we need to do intervention because it doesn't change much. If there is a liver arm dysfunction, we need to do about intervention. If there is a hand function is poor, we need to do about the intervention. But why it is very important to identify dystonia, like I will give you the very simple example. When the child cannot able to do about the hold nicely or release nicely, and that would be most of the common case in the spastic hemiplegic, we can correct with the APSU transfer, APSU to ECRB transfer. But in case of the dystonia, what is in dystonia? They cannot able to do, but there would not be any actually the fixed contraction. There would not be any spasticity. If you try to do the similar transfer, the person will have the fixed extension contracture, and that will be much more severe to deal with that. That's all word of caution would be there in case of the dystonia.
So the next question is, what will you do in that patient then?
It's very little. That's why in beginning I said we can have only available option for the spasticity, muscle imbalance, and deformity. We don't have even at this time have the involuntary movement, incoordination, weakness. These are the issues, and selective motor control. This we don't have the treatment. Even not here, nowhere else. Even that's the patient will have the crouch gait or the stiffening gait because of the poor motor control. The patient can get even the Reynolds Bruller and Freeman Miller has written the chapters and chapters, but ultimately we ask them, what will you do for such? He said nothing. So, but it is better to identify. It is better to identify to avoid the complication, because what happens once you keep your knife, patient is yours, and it will worsen. It's because of our intervention.
And what about the baclofen? So, is there where's the role for baclofen?
Baclofen will have the very good role when there is a intrathecal, very selectively, when local and focal administration like Botox, because if we try to give in journal by a drug, it will require the large, very huge amount. The dose would be very high. and that can lead to the side effect. Many times a child would be sedated. So we have given the baclofen, we give reserve because there would be severe spasticity where we cannot control with effective physiotherapy. We do start the baclofen, even oral, but then would be dose would be higher and there would be side effect also.
Yeah.
And sir, one more
From
question.
DNB,
regarding
I think we need the DNB people, students asking questions.
they have asked one question, sir. Amit,
Okay, yeah.
Hello.
yeah.
Yeah, Gautam,
Yeah.
yeah, come on.
Sir. Good evening, sir. My question is, there in role of hyperbaric oxygen therapy?
Hyperbaric oxygen therapy will not have any role because whatever happened in the permanent damage to the brain, it will remain the same. So it doesn't make much difference in that.
So you'd have to give it at the time when the child was having the hypoxic
Yes.
vein insult, which is impossible. Okay.
Yeah.
Okay, sir. Okay, sir. My second question is, sir, what is compensated and uncompensated crouch gait, sir?
The compensated and uncompensated, because what happened in case of the crouch, where there is a plantar flexion, knee extension, coupling effect will be gone, and that is reason it will be going for the knee in flexion. When there is a persistent flexion more than 20 degree, when there is knee extension inhibitory role because of the flexion, and that will tends to get it more and more and more. So there is no definition clear cut for the compensated and uncompensated, but whenever the flexion deformity or the knee contraction or the hamstring contraction would be more than 20 to 30 degree, it can lead to the uncompensated. It cannot be compensated with anything else.
Okay, sir. And sir, anything like modified Thomas test for hip flexor length?
It is not. It is called as the popliteal shift test. It is not modified Thomas test. Modified Thomas. Basically, when you try to do the ideally speaking and traditionally, we need to do the straight leg raising test to find out about the hamstring length. But when we are lifting it, because of the hamstring, the pelvis is moving. And if we are going to do about the flexion of the other side, then if the iliopsoas contracture is there, it will increase about the popliteal length. So we need to try to flex the hip and see the relax, keep the pelvis in same line, and then we are going to do the SLR. So we need to find out, that is called as the popliteal shift test.
One question from Amit, sir. They want to know, before surgery, do we need one MRI scan?
Of
Probably a spine is
Of
asking. Amit,
spine,
you are there?
Brain.
spine, sir, spine.
Fine. See, if the child has got the birth asphyxia history, if the delayed developmental milestones are very straightforward, there is a spasticity. If there is no issue with the diagnosis, no other investigation in form of MRI spine or brain is required. But yes, if there is an issue like a regressive milestone, if there is a spasticity is not matching, it is a class 5 rigidity, there is a severe rigidity, there is no history of the asphyxia or any other history, then yes, for diagnostic point of view, it may require.
So I think if you have some clinical suspicion that there's something more than just spasticity responsible, then certainly you need to investigate it.
Yeah.
I think a lot of pediatricians or the neurologists get a brain MRI done very often, which I think is just sometimes because they don't want to examine the child very carefully. So they do an MRI to show that there is some spot of hypoxic encephalopathy or whatever you like to call it in the brain to convince them of the diagnosis. But in real terms, in terms of practical management, it is not really necessary.
Yes.
We get a lot of patients coming with an MRI of the brain to you.
It's very common, and they will be very unhappy if you don't see the MRI also, because that's very common.
One question regarding when we are doing something for hamstring, sir. One test is mentioned, hamstring shift test, like if patient having crouch gait. So I want to know regarding that one.
The hamstring shift is, as I said, you need to flex the contralateral hip in order to prevent the pelvic migration. So I will give you the simple the reason. You need to check in horizontal plane when you do about SLR in the knee flexion, and then you do about that from vertical to the tibia. You are measuring the angle. In the hamstring shift test, when you are going to do the contralateral hip flexion, so it will not take care about the hip FFD. Then you actually see about the length of the hamstring. That is a hamstring shift test.
And you mentioned regarding selective motor control, sir. What is
Yes.
that?
Selective motor control means isolated. The person is instructed to do dorsiflexion of ankle because of tibialis anterior. The normal human brain can control. We can control the dorsiflexion of the ankle. But in case of the brain involvement due to cerebral palsy, the selective motor control would be lost. The person cannot able to dorsiflex alone. So there would be mass effect. He was instructed to the flex the entire limb, then you can able to see the dorsiflexion of ankle.
So, sir, it is different from lever arm dysfunction.
Yes,
It is not a
lever arm dysfunction may be because of the poor lever arm, unstable lever arm, short or longer lever arm.
Okay, sir.
Sir,
And yes.
for the management of crouch gait, what all option we have to say in exam, sir?
We need to find out what is the reason for crouch gait. Crouch gait itself is a big topic. It may be related to hip, knee, or ankle.
Yes, sir.
In knee joint, there may be the knee contracture, permanent contracture of the knee flexion deformity, the hamstring contracture, or poor quadricep. If all three would be there, all three needs to be addressed. The crouch gait may be due to the hip contraction, like the fixed flexion deformity due to iliopsoas. It may be related to the hip extensor weakness, or it may be related to the ankle, like over lengthening of the tendon Achilles, or the tibialis anterior stretching. That can lead to the weakness. If it is due to ankle, it will require the orthosis.
And
So
sir,
one of the common iatrogenic causes of the crouch gait is when you
Yeah.
over lengthen the TA, okay?
yes,
Yes.
So, or you lengthen the TA, which you, strictly speaking, you don't do the conventional lengthening of TA or CP. And if you do that, then you have this danger of the patient developing crouch gait.
yes, sir.
So what is, Hitesh, what is the reason that happens? So you lengthen the,
Yeah, because what happened that normally in the upright position, we need to have the plantar flexion knee extension coupling effect. And because of the lengthening of the tendon Achilles, we need to lose about the strength of the tendon Achilles. And the strength of tendon Achilles would lead to the poor knee extension. And the knee would be there in the ankle would be there in persistent dorsiflexion, and secondary to ankle in dorsiflexion, knee will
the
flex.
knee has to flex to walk, yeah.
In order to touch the ground, the foot will be touching the ground.
And
Sir,
sir, during surgery, is it under release or you are releasing appropriately? Like sometimes.
In a dictum in the Eugene
Don't
Black.
over release. Yeah. So you're saying Hitesh, carry on.
Yeah, because it is over lengthening, what I was mentioning.
Yeah, you should never overdo it. Unlike when you're doing for a club foot, you want to try and get maximum dorsiflexion, or in polio, you want to get the foot dorsiflexed. Here, you make sure that you get it to neutral and not actually into dorsiflexion. Yeah. Is that how you work it?
Yes, correct.
And
Sir, any
yeah.
bony correction in crouch gait, sir?
Yeah, if there is a bony deformity, we need to do the bony correction. Like we need to do in elevation with 20 to 30 degree flexion deformity. We can do with femoral shortening with the knee extension osteotomy, along with the patellar tendon shortening surgery with hamstring transplant.
Sir, in femoral shortening, we have to do both sides, sir.
Yes.
It's
Yes.
usually bilateral. So
Okay, sir.
for a crouch gait, it's usually a bilateral problem.
Regarding
Yes.
the Botox injection, sir, after every injection, you put some splint, or is it okay to put crepe bandage?
it's always better to immobilize
So you
the
have to splint it in
splint.
It's always.
cast or splint, whichever.
And sir, sometimes after one orthopedic operation, is sometimes it is possible that one ambulatory patient may become non-ambulatory. So, how to counsel for that with the parents? Sir? That is very difficult one.
It is very common when there is a hip adductor contracture, and when there is a abduction is also powerful. When you do about excessive lengthening of the hip adductor, the child will develop the excessive hip abduction contracture. Similarly, the tendo Achilles, if you try to do over lengthening of the tendo Achilles, it will be worsened and can lead to the crouch gait and ambulant child become non-ambulant. So the dictum in cerebral palsy, do under correction than over correction. That is very, very important.
So, and you also need to then counsel the parents before, because sometimes they come and say, oh, the child can't dorsiflex the ankle. But you need to explain to them there's a reason you've deliberately done that, because otherwise the walking will be compensated.
Yeah.
And
one
so,
single stage operation, multi-level, it is mentioned for CP. Any exception for that, sir?
Yeah, actually I have removed the slide which is given by
CMLS.
yeah, like body surgery. The surgeon, the child was walking with equinus. The surgeon thought it's because of the gastrocnemius. He released the gastrocnemius. Next year, the child walks with the knee flexion. Surgeon releases the semitendinous and went into the hip flexion. And next year they do about iliopsoas. That is called as body surgery. So always examine the hip, knee, ankle at the same time.
So any exception
Try
for
and
that?
assess all the problems once rather than multiple times. Okay. I mean, there may be situations where it may not be possible. That's a different issue. But
that is with growth.
Yeah. Some things will change with growth, and you may have to do it again. And like you may get a hip dislocating later on, and then it's another problem that you have to look at. But by and large, try to do all your releases at one go.
Sir, if there is a deformity in the spine, such like scoliosis, along with the lower limb deformity, which one will be addressed first? Or
That depends on what GMFCS child we are dealing. If we are dealing with the GMFCS 1, 2, and 3, we need to be aggressive for that. But it is unlikely to get the GMFCS 1, 2, and 3. Only GMFCS 4 and 5 child will develop the scoliosis. That depends on the status of the child, socioeconomic status. Doesn't require every time scoliosis surgery. Particularly
and also it depends. So you can have, your scoliosis may or may not be directly related to the neurological problem. Okay, you could have a congenital scoliosis which is separate, then you will deal with it separately. But if it's related to the cerebral palsy, a kind of a paralytic scoliosis, then it's a different management pattern that you have to think of.
Sir, one question. Usually, it is mentioned in the book that you should watch for hip subluxation or dislocation. You should be watchful and you prevent it. So, how to prevent that one? So, every time we should take X-ray of all joints for the patient, or after clinical examination, or something else you are doing?
Both. Clinical examination and X-ray both. There is a guideline, the Australian guideline, Swiss guideline for the hip surveillance clinic in cerebral palsy. In reality, always check about the hip abduction in knee and hip in extension. If the hip abduction is less than 20, always take the X-ray.
So
and GMFC is 4 and 5. Always take about once in a year on X-ray, pelvic both.
Yeah, and they'll also start developing reduced abduction. Okay, if they're able to abduct fully, then the chances that the hip is dislocated are not so high. Okay, but the moment the adduction or the abduction starts reducing, you need to watch out.
During exam, sir, during the practical.
So Reimer's index, what's the present state of its importance?
In case of the Reimer's migration index, we can
Yeah.
take, in case of the non-ambulant, it can be accepted up to 33%.
Okay.
In case of the ambulant, more than 20%, we should be aggressive.
So you would contain the hip. So that could be, depending, it could be just an adductor release or a hip virus osteotomy or whatever, things like that. Yeah.
Depends on the age of the child and the hip dysplasia. If it is associated,
If there's acetabular problem, you have to deal with that as well.
And sir, for clinical examination, sir, so many tests are given in the book. So what the examiner expected that the examiner should perform during that one? Because I have seen that bimalleolar angle test, hypotaxis, hip test for hip rotators, everything is given. So what all tests to be done during the examination, sir?
basically the biarticular muscle, hip, knee, and ankle, anteversion of the hip, and tibial rotation, and the foot.
Okay, sir. If it is a long case, otherwise they will give one joint. So for that joint only we should do, or other joint also we. Yeah.
Always try to do examine as a whole, the hip, knee, ankle, and rotational alignment.
So if the examiner tells you, okay, just concentrate on the equinus deformity, then it's different. But
Sir,
you can't assume that he only wants you to look at that. Yeah.
sir, do we need to perform sensory and motor examination like neurological examination also in CP cases?
Yes, it is to, if it is a long case, you need to do about the examination, because in case of the brain involvement, there is a cortical sensation would be involved, not the fine and touch. But so we need to do about examination, but try to focus more on the spasticity, contracture, the Tardo scale, lever arm, rotational malalignment, and the complication. These are the very basic. If you can concentrate on that, it's okay. You can able to justify this is a case of cerebral palsy.
And I don't think they're going to give you very sort of GMFS 5 patient to do in a as a long case, because that would become very difficult for people to manage.
Mainly CP come in short case, sir.
Yeah,
Yes.
exactly. So they'll
Sometimes
probably
it
give you
becomes-
crouch gait or equinus or something like that, and want you to
But
concentrate.
sir, nowadays we don't have short and long cases. All cases are.
Yeah, but even then they'll probably ask you to, because that whole trying to assess a patient who's got every joint involved, even for a long case, is difficult. Yeah.
And such ITV contracture is also there in CP. So how it is different from polio?
What contracture?
ITP.
ITV contracture, sir.
ITV contracture. In case of the polio, the iliotibial band is the last to affect. So the most of the time it will be normal, and that can lead to the secondary problem. In case of the cerebral palsy, the biarticular muscles are more involved. So the adductors, the medial hamstring, gastrocnemius are more affected. So the iliotibial band will not have much role on that. So it doesn't require the over test releasing of the iliotibial band.
And for Thomas test, sir, we should do Thomas test during the exam in case
Yes.
of CP patient.
Yes, we need to do about the Thomas test, because the iliopsoas is very, very common. Whenever the hip flexion contracture is more than 20, it will require about the release. That is called as iliopsoas recession. Not traditional lengthening of that. We need to release the, or we need to do about the
Muscular
lengthening
tendinous junction.
at, muscular tendinous junction at the pelvic brain.
Sir. And any test for scoliosis also we have to do. It's
Yes,
like
we need to
Adams
think.
test.
So if child is standing, we need to see in a standing and sitting position whether it's a functional scoliosis or the structural scoliosis.
Okay, sir. So I think most of the part is covered.
Yeah, good.
And I have seen, sir, in exam they have asked equinus for management of equinus contracture multiple times, about 4 or 5 times in DN.
Yes.
So
I
I'm
think that's an
request
important
you-
part of it. So
Yeah.
you have to.
if
So I
in
think this
future-
the silver scale test is an essential part. If you do get a case, you have to do that.
Yeah.
F1, F2 again is important that you demonstrate that to the examiner if you
Yeah.
get it in the clinical, and Also, for your theory part, it's important to concentrate on those things. Yeah.
It is actually, that's
I
why.
have some questions.
Yeah.
Yeah, sir. So how long would you, first of all, how would you check the weakness of the muscle? Because many of the times it is difficult to, examine and look for the weakness or the strength of the muscle in a CP child.
Yeah, it's a correct question. It is very difficult to examine the do at motor power 0, 1, 2, 3, 4, 5, but at least we can say poor, fair, and good. If person can able to do about the against the gravity, it will be fair. If it is normal, it is good. If cannot be against the gravity, it would be poor. Okay, so you can say in a.
Would you like to would we scratch the patient or do something?
No, you need to.
Maybe he'll not be understanding.
That is the reason we need to say whether it's a selective motor control or a weakness. Like if a child was able to ask to dorsiflex the ankle, and because of the weakness, if child cannot do it, that is also possible. And selective motor control of tibialis anterior is not the child cannot able to do it. So you need to do about the mass reflex and find out whether it's a tibialis anterior weakness or is it a selective motor control. Okay, the examination of CP is little tricky. You need to do a both examination and see if it is working, and if you do the tendon transfer, it will go in other way. And that is the reason the tendon transfer doesn't have as much role. If you see 20 years back, the poliomyelitis, we need to have a mathematical model. We just do about calculate the muscle imbalance and do transfer. It never failed. Most of the time it will be successful. But in CP, it doesn't go like that, because it is not very easy to find out exact the muscle power calculation, even by experts also.
Sir, one of the teacher has told that normal grading of muscle power cannot be done in the spastic muscle.
Yeah, I said no. The good
said that.
He said similar. I said exactly.
So you can't do the MRC gradings so easily. Yeah.
Yes.
Okay. So my next question is, how long will you advocate physiotherapy before maybe giving botulinum toxin or something?
So I generally take in my practice at least 2 to 3 observation. I will see that it's not getting better. Then yes, I will go for the. And second, sometimes it will hinder the child's development. Like child cannot able to walk and stand, and in those transition phase, yes, you will have the spasticity control. Child can able to walk, but I don't do this any intervention, particularly invasive intervention in non-ambulant. If the child can able to reciprocate, child able to stand and walk, yes, that is just a goal.
So maybe like in months or weeks, would you say for this many
minimum
advocate physiotherapy?
4 to 6 weeks minimum. Two examination, 2 serial examination. That's why I said for the postgraduate, for the CP examination is very difficult, but the answer in one sentence, they can say, I like to do repeat examination. That would be easiest.
Sir, Amit is asking that, one of DNB is asking, where exactly Botox is given? Means, is there any point, specific point?
Yes, that is called as the motor point, but it is given in the muscle. It is given in the muscle belly. That is a motor point, myoneural junction. It is.
It's not an exact point because you're not actually, you could actually, some people actually do ultrasound to give it exactly at the right point, but it's roughly where the myoneural junction would be.
Yeah.
So you clinically assess where you think the muscle belly is getting converted to tendon and put it there. And because that's where the nerves usually innervate the muscle as well. So, but it's not an absolute accurate science in real terms.
And what interval and how many times we can give, sir?
Now it should not be repeated much. Maximally, it should minimum interval is 6 months and maximum is 2, not more than 2. Previously, used to have the 2, 3, 4, 5
Botox injections. We just discussed that because now they found that long term it could lead to muscle weakness, okay, sarcopenia, which is something which we are beginning to understand only now. even with the elderly patients, a lot of the problems are related with sarcopenia.
Yeah.
And this happens even with the patients with CP who've been given repeated Botox injections. So the tendency is to try and avoid using it and use it as little as possible. But would you have the same problem with alcohol then, or is it different?
Obviously, but we don't repeat. Generally, we don't
Okay,
repeat more
don't
than
repeat
two.
it.
We don't repeat.
Okay.
What
Okay, I think we
Can
should
I
call it
ask
a day
more
now.
question?
Yes.
But yeah,
just
Any
Yeah.
question?
So
Go ahead.
again, how long is the brace advice, sir? I mean, would you advise it till maturity or something?
The brace would be advised according to the issue. If we do about the tendon transfer or any intervention, it is 6 months. And the brace is required till the definitive intervention would be done.
sir, if you
Then
allow me,
after
then we
that,
can
if a
plan
surgery
one
is
surgical management of CP, sir, like in equinus and all in future, if that is possible.
What
For
is
like
it?
tendon transfer and bony procedure in future, one class for that, sir.
Yeah, it can be done because in case of the hemiplegic cerebral palsy, when there is the fixed equinovarus deformity, we need to find out whether the gastrosoleus tibialis anterior and or tibialis posterior would be the spastic, and many times it will require the intervention of everything together. By the tibialis posterior, the intramuscular lengthening with the tibialis anterior tendon transfer or split transfer or the Koffers or Hofer's transfer. Combination may be required in many times.
So, sir, in future we can plan one class for that
Oh,
whenever it is
Yeah,
possible.
yeah, sure. I mean, why not?
Yeah,
Yeah, I think maybe just on the surgical aspects, maybe
yeah. Yeah.
or people who, yeah,
Because decision making is very difficult,
Be-
sir, during
because you can't combine all that with everything else, so it becomes too much.
Yeah.
If
Yeah.
you're expecting him to talk to every surgical procedure. So
yeah.
anyway, great, Hitesh, that was excellent.
Thank you.
And thank you very much for coming and helping us out with this. And if there are no more questions, I think we should call it a day and let Hitesh get back to his whatever he plans to do for the evening today.
Yeah. Thank you.
Thank you
Okay,
so
bye.
much, sir.
Thank you.
It was
Thank you very much,
great
Hitesh.
discussion.
Thank
you, sir.
Okay, thanks.
Thanks.
Okay, bye.
Thank you very
Bye.
much.
Thanks. Thanks so much.
Okay, bye.
Yes. And the soap sir is also there. Thank you,
Thank you,
sir.
Dr. Ashok.
Thank you, sir. Janki, you can stop the streaming.
Yeah. Me, sir. Okay.
Yeah.
Okay, sir.
Just near the live on YouTube, you can stop it.
Okay. I'll just see, sir. Oh, actually, that laptop is and that one.
Or make me host, I can do that then.
Okay, sir. Actually, I'll just cut it and restart.
Okay.
I think it is stopped, sir.
Okay.
Just check it. Yes, sir. Thank you so much, sir.
Okay. Fine. Thanks.
Thanks.
So you can end the meeting, it will stop.
Okay.